Dr. Vel sir will be telling the dear audience for this 33rd peculiar series in renal transplant meeting. It has been 3 years since we started this program, and you all know that the Telegram and WhatsApp group is going hectically, and it is delivering a lot of ideas to transplant where many areas were not defined, and many people were helped and got many help from this group. And this meeting is this birth point of a peculiar series in renal transplant. When we started the meeting with Dr. Vel and Sarah 3 years ago during the COVID pandemic, and this meeting has been going leaps and bounds, and we haven't missed a single meeting month. So every month, as we go on, every month we have two peculiar cases from two eminent speakers who will be presenting the peculiar cases. And this time also, we have two peculiar cases, really a peculiar cases, and it's like a odyssey, it's a transplant odyssey. And joining this meeting, I'm very much privileged and introduce Dr. R. Vijaykumar sir, who is happened to my teacher at Stanley Medical College when I did my DM. So as you all know, is very much familiar to the audience of India and South India, and is one who is having a largest number of transplants, one of the largest number of transplants on his credit, around 2,500 transplant. And any complication you tell about transplant, he will have an answer to it. And what is more important and very admiring quality of Vijaykumar sir is he knows what to do at the current position. Actually, with the available resources, available circumstances, what can be done. That decision-making ability and that coupled with intelligence always delivered a very good results to the patients. And I always wondered how he works a lot and used to do a multitasking a lot, and hope in this meeting he will deliver his wisdom of around 30 years of transplant service. And joining him is Dr. Vel.
Thank you, Rajan, for the nice words. Please proceed.
Thank you, sir. Joining him is Dr. Vilas Naik, and he is not new to this forum. Actually, he's a dynamic nephrologist, and he used to jump in with the answers whenever you have put a query on your WhatsApp group. And he did his fellowship from nephrology and transplant from Toronto, and he's a nephrologist at Diamond Super Specialty Hospital, Kolhapur, Maharashtra, and he's also a director of that institute. And Vilas sir is known for his crisp words, and sound knowledge and basics are very sound, and he had a very good experience from what. And though we haven't met him in person, then through his answers and through his discussions, I am very much hope that he'll be having a lot of experience and give you a lot of inputs to these cases. And we have two speakers. One is a veteran, Dr. George Kurian sir from Amrita Institute, Cochin, and he has been serving there for 12 years. He is a product of IKD-RC, and he is not new to the problem. He has already presented a case of nocardiosis, which was appreciated by many audience before. And sir is very much interested in transplant and his academics versus words, and we hope that many takeaway message will be there from his presentation. And I like to introduce Dr. Pani Gopalani, and he's educated and graduated from UK, and he has been here at Citizen Hospital, Hyderabad, and he's a very good friend of mine, and we used to talk a lot through the phones, and he has presented on a few cases in this meeting, in this forum, and he's known for the man who can tackle any complications. Actually, I used to call him like that, and he's a gutsy person and a firebrand nephrologist from Hyderabad, and definitely has the name suggests the transplant odyssey. Going to take us odyssey of transplant and hear a lot of complications which many of us won't be aware of and won't have encountered the situation. Without wasting much of the time, I invite Dr. Pani to deliver his first talk, a transplant odyssey. Over to Dr. Pani. Dr. Pani?
Yeah, thank you. Thank you, Dr. Rajan, for that introduction. Are you able to hear me?
Yeah, you can share your slides, please.
Yeah, I'm just going to share my slides. Okay, I'm going to call this presentation as a transplant odyssey. I'm sure the painting in the background depicts the poem by great Homer. This relates to a journey of a Greek warrior called Ulysses, who, whilst trying to get back to his home from the Trojan War, is encountered with a number of hurdles as he goes through this journey. On the right, you can see the one-eyed monster called Cyclops hurling stones at the boat, trying to dislodge him from the boat. So this story also has got similar difficulties that we had to face and overcome as we proceeded through the course. So the case relates to a 45-year-old male. He's got a primary diagnosis of FSGS. He was biopsied in 2018, but had been lost to follow-up, and then presented last year in August with uremic symptoms. So he was initiated on hemodialysis via jugular line, and an attempted left arm AV fistula unfortunately failed to mature. Before the next fistula formation, I mean, his father came forward to say that he would donate the kidney, though the father is 66 years old and he's a smoker. With that, a pre-op assessment was done. He's had a good exercise tolerance of 2 flights of stairs. He's a non-smoker. There was no prior cardiac history, non-diabetic. His chest X-ray, 2D echo, ECG, and the routine screening was deemed to be acceptable. All his usual pre-surgery specialty clearances were obtained. In terms of his immunological risk, he has had no prior blood transfusions, 6/12 HLA mismatch, PRA for class 1, class 2 were negative, flow and CDC cross-match negative for T and B cells. So this was deemed to be a low immunological risk transplant. Given his financial circumstances, we have planned for steroid-only induction. So he went on to have this live-related kidney transplantation from his father. This is post-operative day 0. He was given methylprednisolone before clamp release, and he was planned for triple immunosuppression. The main renal artery was anastomosed to the external iliac artery, though the plan was to do it to the internal iliac artery because there was a significant plaque disease, so they had to go for the external iliacs. They had to sacrifice a small accessory artery supplying about 10% of the kidney because of technical challenges. Post-op, he has had good urine output, saying that his native urine output is about 1.5 liters. So the next day, we thought the graph was a little slow to function because the creatinine only fell from 9.9 to 8.73. So we just held our nerves. We thought it could be elderly donor with a smoking history. Then a little bit of acidosis, nothing too significant, a little bit of hyperkalemia, 6.1 managed conservatively. Bedside ultrasound showed good graft perfusion, and the Doppler waveforms were acceptable with an RI of 0.6. By the end of the day, he became a little hypotensive. We thought he was adequately filled, and so started him on a small dose of NORAD in order to maintain the perfusion to the kidney. At that point, the urine output was 200 ml per hour. So the next day brings the drama. At 9:45 a.m., whilst he was talking to one of the staff members, he suddenly lost his consciousness. And he was thankfully connected to a cardiac monitor, which showed that he was in VF. That morning, his potassium was 6.5. It was treated before this episode happened with insulin dextrose. So the first thought we had was he's probably hyperkalemic. And thankfully, we had the entire anesthesia team there. So they started working on him. It was a witness shockable rhythm. What transpired over the next 30 minutes was it wasn't a simple VF VT. He needed 6 shocks delivered within a span of 20 minutes because he was persistently in VT. He's received various medications like calcium gluconate, bicarbonate, magnesium, adrenaline, lidocaine, amiodarone during this CPR. And thankfully, after 30 minutes of CPR, he's attained spontaneous circulation. A bedside 2D echo at that time showed extensive regional wall motion abnormality of the anterior wall and akinetic left anterior descending territory, and a severe LV dysfunction with an ejection fraction of 26%. He, even after achieving ROS, he had intermittent episodes of VT, profound hypotension, maintaining a map of about 50 to 60 at best on double strength NORAD full dose. He had severe metabolic acidosis, severe hypoxemia with a PF ratio of 150 and 100% FiO2, and a PEEP of 12. So a decision was made to shift him to the cath lab, and this was about 1 hour after his cardiac arrest. I'll just play this clip. And this cannula is feeding into the left main stem, and there is a plaque sitting right in the left main stem, extending into the left iliac artery. Left anterior descending artery. And this is intravascular ultrasound. As you're going down the left main stem, you could see a plaque rupture. And as we progress, you could see there is a thrombus sitting in the left main stem. So a diagnosis of acute plaque rupture leading to a thrombosis of left main stem was made, and he was stented and was initially started on cangrelor as an antiplatelet, and then subsequently initiated on ticagrelor and ecosprin. And post this, this was around 12 o'clock that day. That's about 2.5 hours from the time of cardiac arrest. He remained in severe cardiogenic shock, and an intra-aortic balloon pump was inserted, and he was just about managing a MAP of 60. He was quite acidotic with a pH of 7, bicarbonate of 8, lactate of 10, severely hypoxic, and he continued to have frequent non-sustained VTs. And the cardiac output was extremely poor, with a cardiac power index of less than 0.6, and anything less than 0.6 is associated with a significant mortality risk. At this point, after discussing with the family, a decision was made to initiate him on veno-arterial ECMO. So, as we all know, ECMO is a process where you drain the blood from the venous system, put it through a pump and an oxygenator, and return the oxygenated blood back to the patient in order to maintain the oxygenation and perfusion to various organs of the body. So we had a significant number of questions in relating to VA ECMO, primarily because the conventional VA ECMO drains the blood from the right femoral vein and then returns the blood to the right femoral artery. But here in this case, we have a kidney sitting on the right side, to the right iliac vessels. So it was a little difficult to try and understand what we should be doing here. The problem being, if we go to the left side for both arterial and venous cannulas, it can lead to increased risk of limb ischemia. So that's one of the major concerns that we had. And the second concern we had was the risk of bleeding. This patient has had 2-day-old anastomosis, and he's already been started on dual antiplatelets. And for the ECMO machine to be running, he would be needing heparin continuously. Also, the risk of infection is a major concern, given that he had multiple lines and he's immunosuppressed. And again, some difficulties in terms of understanding the weaning and decannulation strategies. So after a lot of thinking through, we have decided to go for left-sided arterial and venous cannulation. In order to maintain perfusion to the distal part of the left leg, a 8 French distal perfusion sheath was secured in the left femoral artery, following which a 23 French venous cannula was inserted in the left femoral vein, and a 23 French arterial cannula was inserted in the left femoral artery. And we were monitoring his ACT every 4th hourly, trying to maintain it around 180. Given the post-cardiac status, we tried to maintain his temperature as per the guidance. It is targeted temperature management of 32 degrees centigrade. And then by the evening, it appeared that he's having severe lactic acidosis. Lactates were climbing up to 10, 12. So we decided to start him on CRRT to try and maintain his pH. So the ECMO machine comes with a couple of options whereby you could connect the CRRT machine to the ECMO circuit. So on the top right, you could see the circuit that we have used, where the blood following the centrifugal pump is connected to the CRRT machine, and the return blood is connected back to the ECMO filter just before the oxygenator. And this is what we had to do for this patient. There were significant concerns about his neurological status. It's a witnessed and a shockable cardiac arrest, so we were quite hopeful. At that point, he had absent pupillary reflexes. Very interestingly, he continued to maintain good urine output. A transplant by the bedside showed a good graft perfusion. We continued him on mycophenolate TAC and IV steroids. He continued to receive cotrimoxazole, Valgan, cyclovir, and fluconazole prophylaxis. The next day on ECMO, things were looking brighter, improved inotropic requirements. We stopped adrenaline and he was just on NORAD. We continued with IV, heparin, and dual antiplatelets that included ticagrelor and aspirin. And the CRRT was continued. At the end of the day, he had melena with no acute drop in hemoglobin. We thought it may be just stress-related mucosal injury, and we managed it conservatively with IV PPI. The next day, he was much better. He was conscious, obeying commands, no feature of HIE, significantly reduced inotropes. 2D echo showed improving LV function. However, he's become anuric, and the bedside ultrasound showed good graft perfusion. The next day, all is looking hunky-dory. He's conscious, obeying commands, off inotropes, planned for extubation. TAC levels were adequate, about 10.6. GI bleed settled with IV PPI. He had a little bit of thrombocytopenia at the time with the platelets of about 90. At this point, mycophenolate dose was reduced to 360 BD. Antibiotics, he was just on simple cefparazone, sulbactam. 2D echo, again, better with mild LV dysfunction. And the plan was to wean off ECMO the next 24 hours. So the next day, it was a little tricky in that he's developed what we call as ECMO-associated coagulopathy. The blood components that are exposed to the artificial surface membranes, they can activate the coagulation cascade. It can lead to platelet and microthrombi formation, and it can also lead to anticoagulation, and this can lead to increased risk of bleeding in these patients. He was a little drowsy, and one concern was whether he's brewing infection. His HP dropped to 5.6 from 8.5. It's not uncommon for patients on ECMO to keep needing repeated blood transfusions because of hemolysis, because of ooze, and because of loss of some blood in the circuits. So we thought, well, we know there is a drop in HP. There is no melena again, and we're not very certain as to why this HP dropped. It could have been just a little bit of dilution and other possibilities. But there was no obvious source of bleeding. He has had a little bit of hematuria, not enough to explain his drop in HP. And we thought, this is probably all related to ECMO-associated coagulopathy. Antibiotics were escalated to meropenem, and mycophenolate was stopped at this point, given the concerns of sepsis. So the next day, we were planning to decannulate him, and I get a call at 7 o'clock with this picture. So this is the drain from the site of operation. So when he was being moved in the bed to give him a bath, suddenly there was a gush of blood that filled up the drain bag. It's almost 2 liters. So this is probably where the hemoglobin initial drop happened. So the main concern at that point was there an anastomotic site leak? So he was rushed to the theater as an emergency. So the first thing that we had to do was to stop him off heparin, because this could be the bleeding because of the ECMO-related coagulopathy. So he was the first process was to try and decannulate him, which proved to be not so easy, because at the time of arterial cannulation, they had to go through the ECMO, through the aortic balloon pump incision, percutaneous line insertion. And because it was awkwardly placed in the lateral side of the artery, it became very technically challenging to actually close that rent, during which process he also lost more blood. And then this drain bag was continuing to trickle as we were proceeding through the surgery. As soon as the decannulation surgery was finished, where he needed a small graft to the femoral artery, he was transferred to the cath lab for an angiogram. Thankfully, there was no obvious bleeding from the anastomotic site. And after carefully looking through various sites, they could see selective cannulation of right lumbar arteries and intercostal arteries showed delayed contrast extravasation, even though there was no very clear outright focus of a bleed. At this point, they had to embolize the L3, L4 arteries with PVA particles and coils. And then intra-op, during this particular day, he received 19 units of PRBC, 2 SDP, 10 units of cryoprecipitate, 10 units of FFP. And also, it was a very hairy procedure throughout, because his MAP at some point has dropped down to as low as 50. The next day was a better day. He was clinically stable, no further evidence of bleeding. He was extubated. The blood cultures grew gram-negative bacilli, and whilst he was on meropenem, so we had to add colistin. That day, the blood was about 350 ml from the drain, which looked mostly like an old blood. Because he had an entire replacement of his blood volume, we had to reload all the medications, TAC, steroids, and mycophenolate was withheld in the context of gram-negative bacilli. A bedside ultrasound showed a huge clot in the retroperitoneal space, measuring 6.3 times 11 times 6.1. At this point, CRRT was stopped and he was switched to intermittent sled. He complained of swollen and painful left leg that showed a superficial femoral vein clot, but we were not in a position to anticoagulate him. The next day, the drain output actually increased to 700 ml, and we were worried that there may be further ongoing bleed. A CT angiogram at the time showed only a mild venous ooze at lumbar plexus, and we managed this conservatively, initially by holding the ticagrelor for 24 hours, and we gave him a little bit of tranexamic acid. Left leg weakness, he was not able to move the left leg much, and it was thought to be neuropraxia. The next day, drain output sort of dramatically stopped or reduced, and hemoglobin remained stable, and the drain was removed as we were worried about the clot getting infected. The retroperitoneal clot remained of the same size. At that point, he was doing well, mobilized out of the bed. Urine output improved to 1100. Interestingly, the next day, there was a dramatic reduction in the urine output to 400 ml, and I was not able to biopsy given his dual antiplatelets. Not knowing what else I could do, given that he's off mycophenolate, there is a risk of rejection. I pulsed him with 3 doses of methylprednisolone, and mycophenolate was restarted at 360 BD. Then things seemed to be looking better, and on day 18, he was discharged home with a permacath and him needing intermittent hemodialysis. Just before the discharge, also, he had multiple episodes of hematuria. Each episode was sort of making my heart sink for the next complication. After the DJ stent was removed, his hematuria has settled, and he was advised to continue intermittent hemodialysis in the OP. Post-discharge, we have more drama unfolding. He came off hemodialysis, and his nadir creatinine was 2.4, which I was happy with. The permacath was removed. He was maintained on dual antiplatelets and triple immunosuppression. His developed NODAT, initiated on insulin, and maintained his sugars reasonably well. He also showed intermittent episodes of neutropenia, so during which time I had to keep reducing or playing with his mycophenolate dose. The drain site wound was slowly healing. So we thought, well, we are through the worst, but not. So 6 weeks post-op, he's had this wound from where the drain came out. It wasn't healing well. We tried different courses of antibiotics. Still, there was persistent ooze and slough. And the ultrasound and CT showed large, well-defined separated collection up to 160 cc collection lateral to the transplant kidney. So the 6 weeks after, 3 weeks after the initial injury that he had in the form of retroperitoneal bleed, the clot is still remaining, and we were worried that it is infected. So he was taken for a debridement where there were multiple pus-filled pockets and an infected hematoma. These were debrided. So the retroperitoneal bed was thoroughly washed, and there were 2 large suction drains inserted in opposite directions. I didn't understand the reasoning behind it, but they became quite handy later on. Immediate post-op, he was transferred to the ward. There was a significant drop in HP again from 8 to 4.5. And a repeat ultrasound showed reaccumulation of blood on ultrasound. At this point, we decided ticagrelor is not serving him in any purpose and only causing him trouble. So that was stopped, and clopidogrel was started. Interestingly, he also had resistant hyperkalemia, which retrospectively I think is due to the bleed to the hematoma. So after 3 lots of insulin dextrose, as it was not coming down, we had to do emergency dialysis via temporary line, and he was given 2 units of PRBC. So 3 days later, we get the report that, well, he's growing rhizopus oryzae, which is obviously the mucormycosis. So his troubles are not over yet. So I was really worried for, 1, his graft, 2, his life, if this were to turn into a mycotic aneurysm. So we immediately started him on liposomal amphotericin, and the 2 drains that were inserted in opposite directions, we were able to use it for local irrigation of the wound with liposomal amphotericin. And then I started him on ambisome at 5 milligrams per kilo, which was given for 2 weeks with a plan to switch to isavuconazole. However, 10 days later, the wound was still not healing, and ultrasound revealed persistent collection. So he was taken back to theater for a second surgical debridement. Post-op, just to keep the drama going, he reported cardiac sounding chest pain, and a recheck coronary angiogram revealed a patent stent, and we could reassure him. So I was really sort of paranoid about a mycotic aneurysm, and I was almost pouncing to remove that graft at any time point. And in order to help me with that decision, I got a CT angiogram. What it showed was a hypodense lesion in the inferior pole of the kidney. As you can see in the right CT here, right side panel, there was a hypodense lesion in the inferior pole. And one logical conclusion was this could be a fungal infection. So at this point, I said, we'll forget about the kidney. We'll just start you on conventional amphotericin. So I inserted a PICC line and administered it for a period of 45 days. We were giving 1 liter normal saline each day, along with nifedipine, because every time he gets amphotericin, his blood pressure was through the roof, perhaps due to the vasoconstrictor effect. Thankfully, a recent ultrasound imaging revealed complete resolution of this renal lesion. Now he has been off amphotericin for the last 2 weeks, and wound has completely healed, as you could see here. Thankfully, his creatinine remains stable at 2.6, and he remains off dialysis. So I thought, so in terms of the summary, this is a 46-year-old patient with absolutely no known or purported risk factors for cardiac disease, had to survive through a VT cardiac arrest, a left mainstem thrombosis, multiple episodes of severe hemodynamic compromise, 2 coronary angiograms, 5 days on ECMO, 1 decannulation, complicated surgery, 1 embolization procedure, multiple units of blood transfusion, 4 CTs with contrast, E. coli bacteremia, 14 days on colistin, new onset diabetes, intermittent neutropenia, mucormycosis of the abdominal wound and transplant kidney, 2 debridement surgeries, 14 days of liposomal, and 45 days of conventional amphotericin. And he still lives to tell the tale. So focusing back on what we could have done differently in the first place, could we have picked up his cardiac risk prior to transplantation? So I was just looking at the evidence that is currently available, and it transpires that there is no consensus. ASN and AST guidelines do recommend myocardial perfusion scans for patients if they had diabetes, which our patient did not have, prior ischemic heart disease, which we are not aware of in this patient, or any of the 2 in men over 45 years, ischemic heart disease in first-degree relatives, smoking history, hypertension, the cholesterol levels higher than 200, or left ventricular hypertrophy. So none of these qualify our patient to have a myocardial perfusion scan. Whilst American Cardiology Association and Heart Association, they say no preoperative cardiac evaluation is necessary if the patient has good functional status, whereby they call it as more than 4 metabolic equivalents without cardiac symptoms. And 4 metabolic equivalents would be like doing a flight of stairs without too much difficulty. And our patient could do 2 flights of stairs without difficulty. So what does the KDIGO 2020 guidance says? I'm just highlighting the bit here. In asymptomatic candidates with known coronary artery disease, they should not be revascularized exclusively to reduce perioperative cardiac risk. So even if we were to find that there was a lesion in the left main stem, if he was completely asymptomatic, there wasn't any role for revascularization prior to transplantation. And again, the guidance suggests that all candidates should be evaluated for presence and severity of cardiac disease with history, physical examination, ECG. With signs or symptoms, they should be referred to the cardiology. Patients with asymptomatic advanced triple disease and uncorrectable, I mean, they should not be offered surgery. So patients who are asymptomatic, I mean, not much evaluation is needed. And again, exactly the same sort of ethos was echoed by European renal best practice. In asymptomatic low-risk candidates, basic clinical data, physical examination, ECG at rest, and chest X-ray are sufficient workup. So this particular study, including a large number of kidney transplant patients, up to 17,000, suggested that stress testing pre-transplant is not helpful. They could not show any difference in rates of death and myocardial infarction within 30 days of transplantation. Stress testing in 18 months prior to kidney transplantation is not associated with a reduction in death, total MI, or fatal MI within 30 days of kidney transplantation. So this particular trial, which is not specific to pre-transplant, but it's a ischemia CKD trial that had 777 patients randomized to either invasive strategy or a conservative strategy. And again, invasive strategy offered no additional benefit compared to optimal medical therapy in terms of death or MI. So there was this meta-analysis, which again confirmed no benefit of revascularization prior to transplantation. This included 6 studies comparing this interventional versus non-interventional therapies, and there was no difference in the cardiovascular outcomes. With that, I would like to conclude my talk. And I would like to thank my entire MICU team and the number of different specialists in the hospital that helped me get this patient to the shore. Thank you.
Excellent. Thank you, Dr. Pani. I just want to request the panelists that Dr. George Kurian sir has some emergency work to go on. So he has to leave by 9 o'clock. Shall we complete his presentation and take the questions for the both presentations later?
Okay. Sure.
Okay. Thank you very much, sir. George sir, can you share your slides? George sir? Sir, I think you are muted.
Hello.
Yeah, sir.
Can you hear me?
Yeah, yes, sir. Yes, sir. Yes, sir. Make it as a slideshow, sir.
Right. Fine. Right. Am I audible?
Yes, sir. Yes, sir.
Right.
Go ahead, sir.
Okay. So I'll just have 2 cases from our transplant series. So that's 2 cases of PTLD. The first case presented with vision loss and proptosis. It was a 23-year-old girl. The native kidney disease was IgM nephropathy. And it was a live-related allograft recipient, mother being the donor, and it was done on 22nd of December 2020. It's an HLA match of 5/6, and she was induced with ATG. Then 6 months later, patient presented with a mild graft dysfunction, creatinine from 1 to it had gone up to 1.5. A graft biopsy was undertaken, and it has shown acute T-cell mediated rejection. And she was treated with a pulse steroid pulse for 3 days. And again, in August, initially the graft function improved, but again it worsened and creatinine had gone up to 1.8. Repeat graft biopsy was done, and it also showed acute T-cell mediated rejection. So a repeat pulse steroid treatment was given. And again in September, there was still a further rise in creatinine. A third biopsy was graft biopsy was done. It was showing acute tubular injury with interstitial fibrosis and tubular atrophy. Probably that is secondary to the previous rejection episodes. And so, but there was no evidence of active rejection. So the CNI dose was a bit on the higher side, and it was optimized. And probably on 3rd June 2022, that is almost 1.5 years post-transplant, this a girl had presented with acute visual blurring of the left eye, with which was progressive for 3 to 4 days time. And at that time, the serum creatinine was 1.9. A fundus examination revealed massive edematous optic disc with hemorrhages and exudates. The right eye, mild arterial narrowing and minimal disc pallor. The ocular coherence tomography showed disc edema with the perivascular sheathing. The impression was left eye, the optic disc granuloma with vasculitis. And the probable diagnosis was considered probably is it as CMV-induced optic neuritis or a granuloma with vasculitis. An MRI brain was undertaken, which shows small nodal enhancing lesion, a hyperintense on T2 flare, hyperintensity seen in right parietal, right temporal, subcortical white matter, and one in the right peritrigonal region. Posterior retinal aspect of the left globe shows T2 hyperintensity with the contrast enhancement could represent retinitis. That was the impression given by the radiologist. So a treatment, a presumptive diagnosis of the CME PCR was negative, but a presumptive because the ocular and ocular CNS and intestinal CME could be compartmentalized. So you may not get the PCR, blood PCR, it could be negative. So and in presumptive diagnosis of CME, intraretinal injection of ganciclor was given. And a vitreous tap with a push panel, that was all this virus, that is cytomegalovirus, herpes, mycobacterium tuberculosis complex, toxoplasma, and varicella zoster, all was negative. So then on 3 weeks later, that is on 21st of June, a repeat vitreous sampling was done, which was also negative for all CME and all panel was done, and all this were negative. So in infective panel, it has turned out to be negative. But still, we could not reach anywhere because we had done an imaging, we had done the vitreous sampling. So then probably biopsy granulomatous lesion in the optic nerve. So the patient had gone out to another center for ophthalmic evaluation, and there the impression was the granulomatous lesion in the optic nerve. So probably when you think of granulomatous lesion, the immediate suspicion is tuberculosis. But tuberculosis, whatever we have evaluated, the tests were negative. So we had a talk with the ophthalmologist there in the tertiary eye hospital in Coimbatore. So they said it could be tuberculosis, but all tests are negative. But worthwhile giving a trial of ATT. So the patient was started on ATT. But since the lesion was not showing any signs of regression and the patient was not tolerating ATT, so this patient had gone for an Ayurvedic treatment. For Ayurvedic treatment for since then for 3 to 4 months. So though patient was reporting about the renal status, patient was for ophthalmic treatment because patient had from Amrita, patient had gone to another tertiary care hospital in Coimbatore, and then there also they couldn't give a definitive diagnosis. Patient had slipped out to Ayurvedic treatment. Initially, there was some improvement that they probably subjective improvement, but this was the initial presentation the patient had presented with that. So then there is a progressive decline in vision and proptosis. Then later on, as you can see, the proptosis has increased. And another MRI brain was done in November. That was a left orbital, that was showing a left orbital muscle lesion with a fusiform swelling of, predominantly involving the anterior medial rectus muscle and posteriorly all rectus muscle. And the myotendinous junction appears paired. Gross left eyeball of exophthalmos with a deformation and probably retinal detachment. There is coning of a posterior eyeball at optic disc, probably due to traction. And the left optic nerve is significantly stretched, thickened with a irregularity of the preoptic sheath. And posterior optic nerve and optic chiasma edema suggestive of optic neuropathy, probably due to compression. So the mass was compressing, and there was a retinal detachment and traction on the optic nerve. So possibilities thought was IgG4 related disease, could be a pseudotumor or a lymphoma. So that till that time, a malignancy was not considered, probably because patient had gone out to Ayurvedic treatment and there was no follow-up from the ophthalmology side. Then repeat on December 2020, that's almost 2 years after that means after 6 months of the presentation, patient had presented the severe proptosis of left eye, conjunctival chemosis, severe lag of thalmosis, on palpation, retropulsion and lid closure not possible. Peripheral smear showed normocytic normochromic anemia, leukopenia with a lymphocytic preponderance and many reactive lymphocytes. Neutrophilic series show mild left shift with the toxic granules. Another repeat because the MRI, the previous MRI was done at another center. So here it was repeated again. Was showing large heterointense lesion of the left orbit with intracranial extension and mass effect. So in view of significant diffusion restriction, lymphoma is more likely than granulomatous etiology. That was their impression now. So this was the third MRI. So this was the presentation at that time. So left orbital mass incision biopsy was done on 9th December. Histopathology, it was hematolymphoid malignancy. The IHC staining was found positive for CD20, CD45, and moderate positive for BCL2. And it is a diffuse large B-cell lymphoma, non-GCB type biopsy from superior medial left eye mass. So it was a diagnosis of lymphomas are made almost 6 to 7 months after the initial presentation. So in the initial, probably initial 2 months, it was an infective etiology was high on cards, and it was probably investigated for the same from the mostly from the clinician's point of view. So a PET CT was undertaken on in February. That was a hypermetabolic soft tissue density lesion in left orbit. Surprisingly, no evidence of metabolically active disease elsewhere in the present scan. So it was limited to the orbit. Treatment weekly rituximab for 4 weeks and planned a repeat PET scan after 4 weeks. In April, a repeat PET scan was done and metabolic resolution of the previously seen FDG uptake in shrunken left eyeball. Reduction in size of the metabolic activity of intracorneal soft tissue density lesion in left orbit. So that was there was a resolution of the initial FDG lesions. Rituximab continued for 4 more doses. Patient developed pneumonia after that. So after 2 doses, and then it was stopped. A follow-up PET CT was taken in August. Shows significant interval increase in the FDG of intracorneal soft tissue lesion. So it's a recurrence of the lymphomatous disease was seen. So the patient was subjected to chemotherapy after that. So patient had rituximab, patient had taken 6 doses. Then chemotherapy, including cyclophosphamide, vincristine. So the first dose was on September 22nd, and 6 doses of cyclophosphamide patient had received. Last dose was on 8th of February this month, last month. So this was the chemotherapy cycles. With the chemotherapy, the proptosis and the clinically the lesion has subsided. Patient is due for a PET CT now. So this was the latest photograph of the eye. And latest lab reports were serum creatinine is 2.85. The initially patient had a graft dysfunction. Probably over the last 6 months, there is a slightly creeping creatinine, but and we had already patient is off mycophenolate, and initially patient was on mycophenolate, then on azathioprine, which was stopped at the introduction of rituximab. And the CNI dose were also half. Now so this is the first patient. So I come to the second case. It's a case of throat pain. This patient had undergone a transplant in October, live lateral allograft in October 2021. With the mother as the donor, 3/6 HLA match with induction with ATG, and it is a triple immunosuppression. Immediate post-op, patient had a graft dysfunction. Graft biopsy was showing mild tubulitis with a moderate interstitial inflammation and background. In a background of moderate glomerulosclerosis, the mother was the donor. Probably that's a agent donor. So grade 1 IFTA and hypertensive vascular changes with the C4D negative. That was the biopsy. So though the biopsy report was not very suggestive of it was not suggestive of an antibody-mediated rejection. The creatinine had jumped from 1.4 to 2.5. That was the graft dysfunction that was noticed. So patient was started on therapeutic plasma exchange and IVIG. With that, the creatinine had returned to 1.7. And then this is almost 10 months post-transplant. Patient had presented with the throat pain. On examination, tonsils were enlarged. Left side grade 3 with a pillar congestion. And clinical presentation, persistent throat pain and trismus, not better with antibiotics. On examination, the left-sided peritonsillar abscess with the uvula displaced, grade 4 tonsils. Right side, it was grade 2 tonsils. A treatment with IND and IV antibiotics given. Edema and swelling measuring 3.8 to 2.9 centimeters on MRI in the left tonsillar region, extending into the left vallecular base of tongue and the deeper lobe of submandibular gland, and shows diffusion restriction. So the initial impression was inflammatory mass and persistent throat pain, and left grade 4 necrotic tonsils and congested uvula and thick edematous congested uvula. So this was the picture, and it was a non-healing ulcer. Indirect laryngoscopy, larynx were clear. Biopsy and repeat culture from the left tonsil were taken. And a tonsillar biopsy was showing acute inflammation. Culture and peritoneal from peritonsillar abscess as Klebsiella pneumonia. And he underwent a unilateral tonsillectomy. All the almost the MTB complex, smear for AFB, fungal, all were negative. The only big tissue culture showed Candida cruzi. Histopathology, left tonsil lymph, it's a left tonsillectomy, specifically lymphoproliferative neoplasm. So it's a HCl were positive. It is a findings are of monomorphic B cell post-transplant lymphoproliferative disorder. So this was the histopathological picture. Then staging PET CT was shown. Is the PET was showing a intrapelvic left intrapelvic and left external iliac lymph node lesions were also noticed. So it had come stage 4, but this was not noticed earlier. Treatment with rituximab once weekly and follow-up PET CT. There was metabolic resolution and there was a graft dysfunction which was biopsied, subsequently biopsied also, which was showing mild tubulitis. I'm not going to the details of the graft biopsy because. So this was the after treatment, which was a non-healing ulcer. It healed with the treatment of with the rituximab. Almost it had taken 4 to 5 months for the ulcer to heal. Okay, thank you.
Thank you very much, Kurian sir. It was really a peculiar cases. Both of the cases are really given some take-home points, and we can finish off the discussion with Kurian sir because as he has to leave for at 9 o'clock. So we can start the discussion of PTLD now, and then later we can go to Dr. Pani's case. Over to panelists, Dr. Arvind sir, your comments and your.
Basically, the lymphoma is a great mimicker. Wherever any malignancy comes or we suspect, lung malignancy, for example, thought it's some other lung carcinoma, commercial carcinoma, and no. We found we had to go for a mediastinal biopsy and proved it to be a lymphoma. So lymphoma is a great mimicker. Second thing is with the ATG injection, lymphomas are bound to be commoner. Third message I would think in this is, basically we have to use PET CT a little more, especially in a very complicated case, because we found that in the known cases we are not able to find. PET CT helps to diagnose the malignancies earlier and easier. So I think
sir, you are right. In the first case, if you had done a PET CT, it would have picked up the malignancy better. We had done 3 MRIs. MRIs could not give a diagnosis. Probably if you would have gone ahead with the PET CT in the initial phase, you would have cleansed the diagnosis. But so that is
we are able to diagnose earlier. Earlier. I had a patient, for example, with a native renal cell carcinoma in a transplanted patient after 10 years. So this we could not get it. We had some RBCs positive, few RBCs, nothing positive. Then PET CT only cleansed the diagnosis. So we could remove the kidney without any problem. So earlier diagnosis, when you are stuck, you don't know what is happening, or when you think it is infection alone, do think of lymphoma. Lymphoma is a great mimicker. So always think of lymphoma, keep in your mind. That is what I would say. Others' opinion.
Thank you, sir. Dr. Vilas, your opinion, please.
Yeah, excellent work, Dr. Kurian. Congratulations. Just a question. Did we do Epstein-Barr virus viral load?
Yeah.
No, that was a very good question, and it's mostly no. We don't usually we usually monitor the patients for Epstein-Barr virus in our cohort. This could have been no. If you are monitoring with Epstein-Barr when pre-transplant, do you all screen on the, because almost 90 to 99% of cases it will be positive pre-transplant. So just like that, CMV we screen, but EBV I don't know how many centers screen. And second thing, we had also a case of CNS lymphoma where PTLD, which was in that patient we had done the Epstein-Barr virus, but after diagnosing an Epstein-Barr EBV may not help, but monitoring post-transplant is said to have an advantage if the CMV, the EBV titers are going up. Probably even say the literature says, okay, you may if the titers are going up, probably the ganciclovir treatment would help in containing the virus and subsequent PTLD formation. So we in this case patient we have not done the Epstein-Barr virus, but in another patient who had presented with the CNS lymphoma we had done, and it had turned out to be positive.
Dr. Kurian sir, presently the first case, the patient is on tacrolimus. So is there any plan of switching over to everolimus like at the time?
That's also a very good question. But whatever when you search the literature, either if it is a severe disease, drop off CNI, or a 50% reduction in the CNI dose that is recommended for probably drop anti-proliferative agents. That is one. Second, immunosuppression. Always this is a question where when there's a PTLD, how to go about managing the immunosuppression. So immunosuppression, steroid to continue. Then probably they may have the treatment regime may have steroid like dexamethasone, so they may have that in combination. Second, drop mycophenolate or azathioprine if it is there. Third, reduce the CNI by 50%. That's what it is. And switching over to PSIs. Probably everolimus or sirolimus. Probably it's a thing that can be thought of, but by literature, this is what I could gather.
Okay.
Actually, this patient.
Yes, sir. Yes, sir. Go ahead, sir.
Actually, this patient had a couple of episodes of ACR, and probably switching over to sirolimus would be pushing her graft further down into some kind of rejection, probably. So I think
the thing is that she was a young 23-year-old girl, so they're more prone for rejection. So probably switching over to it will be a difficult decision in that case.
One observation is both the cases had ACR.
ACR, right.
Both were treated for ACR. So it's a really an interesting case. So one has to think of PTLD with isolated.
Even it's
isolated. And thank you very much. If there are no further questions, and thank you very much, Dr. Kurian, sir. Opening to the Dr. Khani's presentation, it was a really wonderful presentation, and your perseverance in protecting the patient, the graft is somewhat amazing. You have tried everything to take care of the patient, actually. So I open the discussion and open to panelists for the discussion, actually.
Actually, the patient course, is complicated very much, and I mean, you have done your best for this, whatever is possible, everything has been done. So there is no question about it. The only question is how early should we have screened before transplant? How much we should do? That is the unresolved question, because we used to do before transplant for almost everybody beyond the age of 40 and all diabetics, angiogram routinely. But that also did not, number of times we don't have to do anything, few times we intervene. And still the post-transplant cardiac events do occur, and patients have even autopsy proved Enterovolemic, a patient who was in narcotic withdrawal. He fainted after 6 months or 1 year after transplant when he was on duty. So they did a postmortem. They found the LAD was blocked. So we could not find it. It was okay before transplant. He was a diabetic. So it is very difficult to predict. We don't know really how to predict. That is the case. So whatever steps you take. So as of now, what we plan is we have angina or symptomatic or heart failure, some severe diabetes, smokers, sexual assault. Some of these, it is all highly individualized. So where we can screen the patient. Otherwise, we won't be able to screen.
Dr. Vilas?
Yeah, Dr. Pani, that was a mammoth effort. Like, we can't think anything could be done more, and it stimulates us to, strive hard to chase the patient as well as the graft in a good way to make him survive. Like, I believe me, I could have given up on him like half the way. When we stick up with chronic patients, nothing is happening good. And you said the economic part. How did you take care of that part? I don't know. You said there were limitations, so you couldn't give him thymoglobulin. And on the other side, you could sell 3 houses and then get him to do this. But this is just phenomenal.
Sure, I think initially I couldn't give him induction because he didn't have the finances. And
Yes.
then he's had extended families and everyone poured in money. It's just like, I think he's probably a very popular guy. I mean, he's a very sweet guy. And he was the most positive person I have ever seen with any of my patients. On ECMO, when he was awake, he was smiling and saying, "That's fine, let's carry on." So I think that attitude definitely helped.
That helps.
Absolutely. I mean, his family, extended family, he's got a lot of cousins in the US. They just poured in money. And I was also thankful to the management of the hospital, who's almost waived off 11 lakhs of his bill. So, so I
A small fraction of his bill.
So, yeah.
So what is the immunosuppressant he's on at present?
At present, he's on mycophenolate, myfortic 360, tacrolimus, maintaining levels of about 8 and 5 milligrams of Visalon. The standard is back on top.
Dr. Pani, actually, I can't stop admiring your management. And one few questions from my side.
Sure.
Have you checked for dyslipidemia? You repeatedly check for dyslipidemia for all pre-transplant patients, actually.
Correct. I mean, his LDL was about 140, 150s. So it's not super high, but his HDL was quite low. So perhaps we could have acted on that beforehand, or
also he had a lot of plaques in the internal iliac.
Correct.
That's the reason for you to do the stenosis at the external iliac.
Correct.
Another one important point, actually, he had a graft dysfunction, and thinking in terms of rejection, he have given steroids, pulse steroids. Whether that could have been averted at that point. So later he had developed a mucor and everything. So
Correct.
Pulsing steroids, pulsing patient post-transplant, I always see more threat than giving ATG injection pre.
Maybe your comment is quite valid here. And I guess I could not explain why the why your output would go from 1100 and increasing to suddenly 400. And there was absolutely no hemodynamic issues. There was no clear evidence of sepsis at that point. In fact, the sepsis parameters were getting better. His graft showed a well-perfused kidney. So I couldn't think of anything else. And I was clutching my straws. So,
yeah,
and at that point, I mean, in the context of whatever is happening, I didn't think that was sensible. And also, he had episodes of intermittent neutropenia, which would have caused led to mucor. He also had NODAT, which could have led to mucor. So a number of elements here. Perhaps that decision may or may not have been correct. I don't know.
No, it's just a comment from my side, because he has received a contrast and he was hypotensive, a shock, and there is every reason he should be having some ATM. That's no issues. And another one interesting point, you told that you have put an nifedipine with saline. Can you explain what is that actually?
No. I mean, these are given separately, not together. Because first I mean, obviously there is some evidence to say amphotericin causes renal vasoconstriction, leading to graft kidney dysfunction. So very interestingly, we start him on amphotericin at 10 o'clock. By 12 o'clock, his blood pressure used to shoot up to 180 over 110, 120. Then I thought, okay, well, nifedipine may do the dual job. And there is also some evidence to say that nifedipine may reduce the risk of kidney dysfunction with amphotericin. So I thought, why not use it for both? So we were religiously giving him nifedipine at 10 o'clock, just at the time of starting amphotericin. And then his blood pressure used to be perfectly stable. And interestingly, he's not had any dyselectrolemia, and his creatinine stayed rock steady. I think his dad likes him very, very much.
An important question. Actually, you have switched to liposomal amphotericin, conventional amphotericin. What is the rationale for that at the time?
It's just the appearance of this hypodense lesion in the kidney, and liposomal amphotericin is it doesn't penetrate the kidney tissue, as far as I understand. So that was the reason why we switched to conventional amphotericin.
Okay. We could take some of the chat questions.
One comment rather. This pre-transplant evaluation for coronary disease doesn't come with a lot of robust evidence, right? It's all retrospective studies. One study is coming up, the CARC study, the Canadian-Australian study, which they have started in 2019. They are enrolling prospectively 3,300 patients, randomizing them to intervention and then to conventional therapy. Probably we might get answer in another 5 years. There's a study coming up prospectively for coronary intervention pre-transplant on the waiting list, and they are supposed to be followed for 1 year post-transplant for acute coronary events like sudden cardiac death, myocardial infarction, and non-STEMI. So this is an ongoing study. They have enrolled patients. It's like 3,300 patients are supposed to be enrolled, and probably might get answers that should we really evaluate with more aggressive angiographies and etc. That's
yeah. I think it'll be interesting to wait for that. Yeah.
Probably would have gone through the literature of pre-transplant cardiac evaluation and all. It's still a very gray area. Even I had a bad experience of a patient who is a diabetic. We used to do a routine angio for all diabetics. He is a 60-year-old, 55-year-old. We did an angio. It showed only 30% of block in LMCA. And he was on optimal medical management, and we proceeded with the transplant. As there was in as Indian guidelines are also that asymptomatic coronary artery disease doesn't need any further treatment. Immediate post-transplant, he developed acute coronary syndrome. Eventually, I lost the patient, actually. So this is a big gray area, how to evaluate, how to manage coronary artery disease, asymptomatic coronary artery disease going for a transplant. Do you have any idea of stress thallium? What is the indication when to do a stress thallium and all? If you would have gone through the literatures and all, which patients are need stress thallium, and the coronary angiography, not being to CT coronary angiography, could it suffix your coronary angio, direct coronary angio?
Yeah, I think if you look at the ACCA and AHA guidance, I think they only recommend perfusion scan in patients with risk factors, like with diabetes, prior history of or first degree relatives having coronary artery disease, or if they're metabolically, I mean, what do you call, their exercise tolerance is not great. Those were the patients it's recommended. And as you rightly said, you were one of the patients that you lost with a reasonably okay angiogram to end STEMI to plaque disease is one such thing where you could be having minimal luminal narrowing, but still present with a catastrophe. So when the plaque ruptures, obviously this is quite an thrombogenic material that gets exposed, leading to platelet accumulation and thrombus formation. So I guess it's like being hit by a bus after having a successful renal transplantation and dying from it. So I guess there are only certain things that we could do to try and reduce the risk, like as you discussed, statins and other things in these patients. But are we really able to prove or disprove that there is a stenosis that is significant? And even if so, if they are asymptomatic, what evidence have we got saying that revascularization is actually going to benefit them? So I think these are questions.
So another thing is, in calcified coronary, these regular CT angios will not be infected. So that is a big problem for us. A lot of patients do have coronary calcification, and we can even see it in plain X-ray. So much we see. You don't see in such. Here, renal failure plus diabetes. Better now.
Yeah.
If there are no further questions, Dr. Vilas, your comments, anything, any questions?
No, it was a phenomenal effort. It was a phenomenal effort. It
Thank
pushes
you.
us to try harder.
Yeah, definitely. And if there are no further questions, we are coming to the conclusion of the program. But really, two very good presentations to start with, and we had many learning points from these both the cases, with a worthwhile discussion from both the panelists who took time to spend with us. And thank you, Dr. George Kurian sir and Dr. Kani for their excellent presentation, workup, and preparing the slides, and the panelists who given fantastic inputs into the cases. And I always thank the audience who have always supported us for the past 3 years with the program. And I must thank the MQ team for giving the technical support. And we request the members to present the cases as much as cases present as possible, so that we can learn together and happily live together. Thank you very much for the patient hearing, and we will see you next month.
Rajan, Arvind, for the wonderful telegram.
Thank you, sir. Thank you very much, sir. Thank you very much.
Thank you. Thanks, everyone.
Thank you, sir. Thank you very much.
Thank you so much.
Thank you.
Thank you.